The effectiveness of CBTP for adults with schizophrenia. The main purpose of this presentation will be to outline the key principles of cognitive behavioral therapy for psychosis, CBTP, and then critically evaluate the evidence for the effectiveness of CBTP for adults with schizophrenia. Schizophrenia is a severe mental health disorder and affects more than 21 million people worldwide. The Diagnostic and Statistical Manual, DSM-5, is used to diagnose schizophrenia. Diagnosis requires 2 or more positive, negative, and/or disorganized symptoms to be present for at least 1 month. Positive symptoms include delusions, hallucinations, behavioral discontrol, and thought disorder. Negative symptoms include affective flattening, alogia, avolition, anhedonia, and attentional impairment. Disorganized symptoms include rambling speech, erratic behavior, and inappropriate affect. These symptoms can severely affect an individual's social life, employment, and ability to perform day-to-day tasks. Individuals find it difficult to manage these symptoms, therefore effective treatments are crucial for providing necessary support. There are several treatments for schizophrenia, including pharmaceutical treatment that provides antipsychotic medication to patients, and psychological treatments such as family therapy, arts therapy, and CBTP. CBTP is a psychological treatment that helps individuals with schizophrenia to create links between their thoughts, feelings, physiology, and behaviors. CBTP helps individuals re-evaluate false perceptions, beliefs, and reasoning, and provides alternative ways of coping with target symptoms. Individuals with schizophrenia are helped to recognize delusional thoughts and are provided with help and advice to avoid acting on these thoughts. CBTP also reduces individuals' distress by constructing a model with the patient that makes symptoms and distress more understandable. Cognitive interventions in CBTP explore evidence to disprove delusions, and behavioral interventions identify existing coping skills and teach new ones. However, CBTP does not get rid of positive symptoms such as hallucinations. Several meta-analyses of RCTs, randomized controlled trials, evaluate the effectiveness of CBTP for schizophrenia in adults against control groups. A review of meta-analyses summarizing outcomes of CBTP for schizophrenia found significantly less positive symptoms and greater long-term effectiveness in CBTP treatment groups compared to control conditions at post-treatment. High effect sizes were found for schizophrenia, suggesting that CBTP may be significantly effective for treating symptoms of schizophrenia in adults than standard care. Another meta-analysis found similar results, indicating that CBTP was effective in improving the mental state of individuals with schizophrenia and led to fewer dropouts, increasing the reliability of these findings. This indicates that CBTP may be effective in reducing positive symptoms in adults with schizophrenia in the long term, as high effect sizes were found. However, the RCTs reviewed had a limited range of outcome measures, including few measures of quality of life and the lack of specification of the primary outcome measures. This implies that results may lack accuracy and may not be reliable in explaining the effectiveness of CBTP for quality of life improvement in schizophrenia. The review of several meta-analyses reported an average of multiple effect sizes from individual studies, which may have given some studies more weight than others. and made it difficult to interpret outcome findings by overlooking successes and failures of the studies, implying that results may be biased. Nevertheless, high-quality meta-analyses studies were included in the review, suggesting good internal validity and more accurate results. However, one meta-analysis of RCTs found that CBTP was not effective in reducing symptoms in adults with schizophrenia. The meta-analysis revealed that CBTP did not reduce schizophrenia symptoms more than control interventions, such as befriending, during a 5 to 9 month period. Findings also suggested that CBTP was not effective in preventing relapse. However, results may have differed with longer CBTP treatment. These results suggest that CBTP may not be effective in reducing schizophrenia symptoms and preventing relapse in adults over a 5 to 9 month period. Nevertheless, contradictory results were found by another RCT study which investigated the effectiveness of CBTP in reducing positive symptoms over a 5-week period in schizophrenia patients. These results revealed faster improvement in the CBT group than routine care controls. Nevertheless, the study used a predominantly male sample, implying results may not be generalizable to female individuals with schizophrenia. The RCT method gives the results less power than the results of the meta-analysis. Nevertheless, blinding was effectively used, preventing bias on the part of study administrators and ensuring accuracy of results. The results imply that CBTP may be effective in quickly reducing positive schizophrenia symptoms over a 5-week period. However, differences in the results implied that careful consideration needs to be taken when assessing the effectiveness of CBTP over different time periods. Some meta-analyses and systematic reviews of RCTs demonstrate moderate effectiveness of CBTP for adults with schizophrenia. A meta-analysis revealed that CBTP has a small therapeutic effect on functioning at the end of treatment, but these benefits are not evident at follow-up. CBTP had a small benefit on distress. However, this became insignificant after evaluation of possible publication bias. The studies used small sample sizes, suggesting low power of CBT trials. Another meta-analysis and systematic review found that CBTP reduced the schizophrenia symptoms, but the effect sizes were in the small range. Effect sizes further decreased when sources of bias were controlled for, particularly blinding. Some studies did not use blinding and others used blinding, but this became progressively more compromised during the trial. However, publication bias did not significantly influence effect sizes. This implies that CBTP may have a small therapeutic effect on functioning and have a small effect in reducing symptoms of adults with schizophrenia. CBTP may have a small benefit to distress, as there are differences in findings about publication bias and its influence on results. However, CBTP's effectiveness may be exaggerated in some studies due to potential bias, including lack of blinding. Several studies measure CBTP's effectiveness for adults with schizophrenia against other treatments. A meta-analysis examined whether CBTP is more effective in bringing about a change in delusions in adults with schizophrenia than treatment as usual and other psychological treatments, including supportive therapy, problem solving, and family interventions. Results revealed that CBTP is more effective than treatment as usual, but not more effective than other treatments in bringing about change in delusions. A randomized comparison study comparing the effectiveness of CBTP against psychoeducational treatment for patients with schizophrenia found similar results. Both CBTP and PE were led to significant symptom improvement post-treatment and at follow-up. However, patients in CBTP groups were significantly less rehospitalized, demonstrated a lower relapse rate and higher compliance than patients in the PE group. Another comparison study found that CBTP was more effective in reducing symptoms and social functioning of patients with schizophrenia in China than supportive therapy. These studies demonstrate varied results about the effectiveness of CBTP for schizophrenia against other treatments. A meta-analysis suggested that CBTP may not be effective for PE treatments in bringing about change in delusions. These results may be more accurate due to greater power than the randomized comparison studies. Randomized comparison studies indicate that CBTP may be more superior to PE and ST in reducing symptoms, rehospitalization, relapse rates, and increasing compliance and social functioning. However, the inclusion criteria was limited to the Chinese population and inpatients with schizophrenia, suggesting that results may not be generalizable to other schizophrenic adults from other countries or other clinical populations. To conclude, the majority of studies indicate that CBTP is an effective treatment for adults with schizophrenia. Several studies have demonstrated that CBTP is effective in reducing positive symptoms in schizophrenia over short-term and long-term periods. CBTP may have a small therapeutic effect on functioning and small benefit to the stress. It may also be more effective than PE and ST treatments in reducing symptoms, rehospitalization, relapse rates, and increasing compliance and social functioning. However, there are varied results about the short-term effectiveness of CBTP on schizophrenia symptoms. Additionally, varied effect sizes were reported, indicating that it is unclear to which extent CBTP is effective in reducing schizophrenia symptoms. Mixed results were found for the effectiveness of CBTP treatment against PE, with a meta-analysis implying that CBTP is more effective than PE and other psychological treatments, whilst a randomized control study suggested that CBTP is superior to PE. The results of the meta-analysis may be more accurate due to greater power in results, suggesting that CBTP may indeed demonstrate the same effectiveness as other psychological treatments for schizophrenia. Caution needs to be taken when using this research evidence due to the limitations they present. The RCTs used in some meta-analysis studies included a limited range of outcome measures and lack of specification to outcome measures. Results from individual RCTs may be less accurate than meta-analysis results due to less power. Reviews of several meta-analyses may overlook success and failures of the studies and give some studies more weight than others when averaging multiple effect sizes. Potential bias has been demonstrated in some studies, including publication bias and lack of blinding, suggesting that CBTP's effectiveness for schizophrenia may be exaggerated. Generalizability issues were also demonstrated with male gender dominance in samples, inclusion of only inpatient populations, and limiting the sample to one country. Nevertheless, some studies also demonstrated strengths including the effective use of blinding to prevent bias. Meta-analysis produced more accurate results with greater power, and incorporation of high-quality studies in meta-analytical reviews were also evident. Future research could include more outcome measures, more specifications of the primary outcome measures, and incorporate successes and failures of the study within the findings for more reliable and less biased results about the effectiveness of CBTP for adults with schizophrenia. More meta-analysis studies are required for conclusive results about the short-term effectiveness of CBTP. Future studies could ensure consistency of blinding and reduce publication bias for more reliable results about the effectiveness of CBTP, and also include participants from other clinical populations, countries, and genders for more generalizable results. Continuous research needs to be conducted to evaluate the effectiveness of CBTP for adults with schizophrenia within the field of clinical psychology to ensure therapists are up to date with the most effective treatment approaches and decide on delivering CBTP treatment to patients.